like to do a little bit first of getting to know you a little bit. So could we start with, first of all, who works in Minneapolis? Okay. And who works in St. Paul? Okay. And who works someplace else? Where do you work?
I work both here and in Boston.
Here and in Boston. Somebody else had their hand up? Brooklyn Park, Brooklyn Center. Anybody else?
In the metro area.
In the
Paul, Minneapolis, both of us.
Okay, so you're a little bit of everywhere. All right, great, thank you. Then I have another one. So how many of you have held your current job for less than a year? Okay, some of you. How about 1 to 2 years? Okay, more than 2 years. All right, so kind of a split. All right. Okay, one more. How many of you work in a clinic setting? A doctor's office, that kind of thing. How many of you in a hospital setting? Some of you? And okay, a bunch of you didn't raise your hands. So where else do you work? Retired public health nurse? A student? Anybody else? Okay. Pardon? Out in the community. Okay. Great.
Out in the community, yeah.
And out in the community here too? Okay. Good. Well, welcome. We're going to talk a bit about Ebola today. I know it's been in the news a lot, and so you may know a lot of things about it already. Hopefully, by the end of today's conversation, you've had a chance to ask any questions that you've gotten or questions that you've gotten from your children or your colleagues, because they know you're an expert on health stuff and they come to you and ask you questions, right? Would be my guess. All right. So these are not going to be great, and we're sorry about that. We have a little too much brightness today, but I can walk a little bit. This is a picture of the virus that you see under the microscope. And Ebola is traditionally rare, but it's also very deadly. And there are several different strains. The strain that we're dealing with right now is called Ebola Zaire, and it is one of the more deadly strains that we're dealing with. It can cause disease in not only people, but in some of the animals like monkeys and gorillas and chimpanzees who have some similar characteristics physically to people. It's a fairly new disease. It's one of the emerging diseases. It was first identified in 1976. It doesn't mean that it wasn't out there before then, but that's when it first became a known and recognized and named disease. And it's capitalized because it was found and it was named near the Ebola River. So that's why you'll see that it's given a capital letter. We have seen outbreaks in various parts of Africa. It's particularly been linked to Africa. We don't really know who the natural traditional start host was or where this originally came from, but we think it's animal-borne and that bats even might be a likely host. So as bats get ill and bite or attack other animals, it's spread and then to humans. Right now we're dealing with the largest Ebola outbreak in history, and it's the first time we've seen it in West Africa. It's been more in other parts of Africa. One of the things I forgot to say at the beginning is if we have questions as we go along, please ask them. Feel free to raise your hand and ask a question as we go. As of yesterday, the numbers were increased. We have now seen over 16,000, almost 17,000 cases and nearly 7,000 deaths. And again, that's a very high death rate. We also think that these numbers aren't probably the whole picture, that there are probably others who either did not get to a healthcare setting or the system isn't counting or some other reason. So this is probably a low end of the numbers. And quickly, it's spread through direct contact with a sick person's blood or body fluids. And we'll talk about that a little bit more. And things that have been contaminated with their body fluids, like needles. So if you've drawn blood from a person with Ebola and then you stick yourself, that's a direct contact kind of situation. So one of the things that, oh dear, well, okay. You have to use your imagination a little bit because this is kind of hard to see. But one of the things that we've heard has happened is everyone from Africa is considered suspect. And I want to talk about that a little bit because this is a picture of the continent of Africa, and here's a picture of North America. And the area of concern is over here, and the distance from one part of that area to another, just to give you scale, is about as far as it is to go from Minneapolis to New York. When you look at the whole continent, though, it's farther to go from Miami to Anchorage than it is for all of Africa. It's really important to help people understand around our state and around our country, and we seem to be somewhat geography challenged these days, how enormous the continent of Africa is, and that we don't often think about that we're at risk of a measles outbreak in Anchorage here in Minneapolis, and I think the same thing holds true for Africa. We need to be very mindful that this is a very small part of Africa. It's awful and it's deadly where it is, but it is not everyone in Africa, and that's been one of the things that's been important to talk about. So I mentioned before some of the causes or the impact of Ebola, but I want to talk a little bit more in detail about the symptoms that you would see with Ebola. And symptoms start anywhere 2 to 21 days after you've been exposed. So it starts pretty quickly. There are some diseases where it can take a couple of weeks, but with Ebola it usually starts fairly quickly. So one of the most important symptoms is fever. Okay, one of the challenges is you get fever with a lot of stuff. So that it's not going to, I've got a fever, therefore I've got Ebola. In fact, we hear stories about kids going into the school nurse's office to say, I think I've got a fever, it must be Ebola, you know. So fever comes with a lot of stuff. And you also may have many of these other symptoms: headache, diarrhea, vomiting, stomach pain, muscle pain. The one that is probably more particular to Ebola is unexplained bleeding or bruising. That often comes a little bit later in the symptoms. But when you look at these symptoms of fever, headache, diarrhea, vomiting, stomach pain, muscle pain, what else might that indicate? Influenza, malaria, maybe tuberculosis, maybe food poisoning. There's a lot of things. So it can be difficult to say just based on symptoms. The bleeding or bruising, as your body becomes more attacked by the virus, you're going to see more impact, and you'll start to see the bleeding that people talk about. I mentioned already it's 2 to 21 days before symptoms start. And during that time before symptoms, the person is not contagious. Again, you need to be exposed to the person's blood or body fluids. And another important point that I think has gotten lost a little bit in some of the conversation is that the longer you're sick, the more infectious you become. So the early days, when someone is just first starting to have symptoms, there's not a lot of virus yet. And there's not a lot of the risk of exposure, the risk of spreading is much less. But as the person gets sicker, they start to have more diarrhea, more vomiting, more bleeding. There's more likelihood of transmission. So it's more dangerous as the person gets sicker. And I think we've seen that in some of the cases. Here's a question over here.
What's the question? So you were saying that how specifically to the bleeding issue, is it just from a cut?
I have a
Oh.
question. If you have a bruise, I'm talking about the bleeding, the
Mhm.
symptoms of bleeding, do you need a cut first to start bleeding, or does the bruise start bleeding by itself? How does it work?
With the bleeding, you start bleeding throughout your body. So you may hear about people are bleeding from their ears, from their nose, from their mouth, even from their eyes. So it's just your internal organs start bleeding. So it's not about just a cut and you keep bleeding a lot. But it could include bruising. You will see under the skin that you're bleeding under the skin. Does that help?
Those are internal bleeding?
Yes. Yep.
Okay, thank you.
Yep. And then there's a question in the back.
Yeah, I understand that incubation period
Mhm.
for this strain is important. How does it compare to the previous strains? Why are
That's a great question. How does this compare to other strains? I don't think there's a lot of difference, but I'm not fully up on that. But if you want to know, give me your contact information and I can get that back to you afterwards. Yes, another question.
My question is in regards to the clinic, in the clinic setting,
Mhm.
you know, the line, as far as, you know, here's all the, what's actually being posted in clinics. The symptoms and what they're saying here is not similar to what's being posted in clinics.
Oh,
I don't know if you've seen the signs, set up in the clinics throughout the Twin Cities.
I've seen some signs.
If you're gonna travel outside the
Right,
country, this is
right,
what's, you know.
right. Yeah, we're going to talk about travel in a little bit. Because
Sorry.
no problem.
Jumping again.
Because the symptoms are important, but the risk factors of travel is the other critical component of this. So we look at both of those together. Mentioned, as the person gets more sick, they're more infectious. That is also true once the person has died. They're still infectious. And that's one of the issues of transmission that we're seeing in West Africa, is that there is a lot of ritual and activities that the family does in helping prepare the body after death that have probably contributed to some of the transmission. And so there's been a lot of efforts to help people understand and to do that work more safely. There's an important part that's different about, about Ebola versus influenza or other diseases. There are some diseases that are airborne, like measles, for instance. If some person in this room had measles and the rest of us had not had our vaccination, the measles germ hangs in the air for hours afterward. And we've seen outbreak after outbreak where someone with measles was in the doctor's office, and then 2 hours later someone comes in who wasn't immunized or their immunization wasn't fully effective. They can come down with measles. So that's an airborne. It just kind of lingers in the air. Ebola is what's known as droplet, where there's actual droplets of fluid. And this next picture, which I love, gives you kind of that sense. Oh, you can't see it very well. But anyway, she's sneezing, and there's all kinds of droplets going into the air. And if those droplets get on you, that is one of the reasons that we encourage, recommend, and support that you cough and sneeze in your elbow, how important that is, and that you wash your hands afterwards. And at some point, you get to the point where you see somebody sneezing in their hands and you're like, oh, don't shake hands with me. Don't you wish everybody was doing that? It's really fun to see all the little kids who know and are being taught that in school about coughing into their elbow and sneezing. But this is what we mean by droplet, is that it's actual physical particles that are getting into the air. So let me talk a little bit about what's happened with the current situation and kind of what's happened. And this is going to be probably more about what's happening in this country. We know how devastating it is being in Africa, in West Africa, in the countries that are affected. And we know that there's been a tremendous amount of concern and a lot of work that still needs to be done. And the news that you hear that things are getting better in some parts, like Nigeria and another one that I've forgotten now, have been declared Ebola free. But Mali has been added, so it's still moving a bit. But the first case that came to this country was the end of September. Arrived in the United States on September 20th, began to be sick on September 24th, so within that 21-day time period, went to the hospital, unfortunately was not identified as someone at risk for Ebola at that time, but then came back to the hospital on September 28th. There were 48 contacts from that person, and unfortunately Mr. Duncan died, and however none of the other people who had been in contact with him went on to there were two people who then developed Ebola from contact with him, and both of them have recovered. Family members, again, I mentioned earlier, in the early stages of disease, you're not terribly infectious. None of the family members or the people who had a lot of intimate contact with the patient became sick. It really was the two healthcare workers who were taking care of him after he became very sick and were exposed to a lot of body fluids. I heard one report say that at that time when you're very sick, you're putting out 2 gallons of body fluids, whether from vomiting or diarrhea or sweat, per day. So there's a lot of possibility of exposure. I think we didn't understand that at the beginning. There's been, I'll show you a picture in a minute of the protective equipment that's recommended for caring for someone with Ebola, and that there's a lot of opportunities and challenges for putting it on and taking it off correctly. And then there was a lot of discussion about, well, should every hospital be able to take care of someone with Ebola, or does it really require some specialized skills and preparation? And at the beginning, before we understood as much as we do today, the feeling was every hospital ought to be able to take care of a patient with Ebola. It's just traditional precautions. But as we've learned, that is an inadequate response. And so now what we're saying is every hospital ought to be able to take somebody in and identify and evaluate them, and then once they're tested positive, they'll go to a special hospital who have done the training and have the equipment on hand. But originally the CDC recommendations were for a gown and a glove and goggles and a mask. And what's changed is now you need a fully covered hood. They want no skin showing anywhere. So you're completely covered. And one of the true Minnesota stories about this is Children's Hospital in St. Paul was practicing the putting on and the taking off of all of this specialized clothing, and the supply of hoods like this was very limited. So they called on their auxiliary, and the members of the Women's Auxiliary of Children's Hospital sewed practice hoods so they could practice using hoods. So instead of making baby quilts, they were making hoods for practicing. So now we've got a face shield and mask. You still have those things on, but now you put a hood over it. You have 2 layers of gloves. You have a standardized suit that is doesn't allow fluid to get through, and you have shoe covers that come up past your knees. So what do you think one of the challenges would be if you were asked to wear this? taking it off when you're done and taking it off carefully, because if there's body fluids anywhere, you want to again make sure you're not exposing yourself. You might get hot, indeed. And do you think you can see very well? No. Do you think you can talk very well? So you've got a very sick patient, and you're trying to be compassionate and caring, and you've got 7 layers between you and the patient. It's a little hard, I think, on everybody. Yes? If you have to go to the bathroom, you're kind of in trouble, yeah. Yep. Yeah, because you would need to take it all off, go do what you're going to do, come back. But pretty much people are about able to manage about 2 hours at a time before they have to get out and do something else. Yes? 2 layers of gloves, double gloving. It's a little more difficult to be able to care and do a lot of sensitive work. You're right. But many surgeons double glove now, depending on the kind of surgery they're going to do. So it depends on the type of gloves you do, but it's more restrictive. Well, I don't know if any of you are old enough to remember when dentists didn't wear gloves at all. Anybody? A couple of us. It was a big change when we moved from not wearing gloves to wearing gloves for a lot of procedures, or giving shots even sometimes. I think people are wearing gloves now. So it's possible to do, but it takes training and it takes practice. Yes?
I hope I'm not jumping ahead, but how long would it stay on this sort of like, because they know they said when you take it off, it's careful.
Yes.
So how long does that stay, how long is it active for?
It's a while. Remember I said the body is still contagious, so I think you should expect that the waste is still an issue. I don't know that we know exact hours or things, but it's a while. It's still there, right? Okay, so I mentioned as well that one of the things that is being done is attention to travel and attention to screening. And so there's been a lot of things put in place to screen people who might be at risk. And we talked about earlier, one of the things you look for are the symptoms. The other part of that, though, is might you have had an exposure? Because again, we're not all of us at risk of Ebola. So all travelers coming from one of the affected countries have their temperature taken at the airport. Then they ask some questions about what's your health? Are you feeling okay? Do you have any of those fever, headache, nausea, vomiting, any of that stuff? And then what's your exposure history? Were you working in a hospital? Were you taking care of patients with Ebola? Were you doing any of that kind of work? And then they also are evaluated just by looking at someone. So I'll have a story to tell you about that in a little bit. If they've got any of the likely symptoms or they had possible exposures, they are asked to step aside and they get further evaluation before they're allowed to travel. And if they think there's concerns about their health, whether it's Ebola or something else, they are asked to see a healthcare professional and to get evaluated so that they're not flying on commercial flights.
I have a question. What about
Yes.
our military personnel?
They're handled separately, and
Oh, it's a separate.
yeah, the military that are being sent over, and we actually have a group of folks from the Red Bull group going over. Yeah, they're going over this spring, and will be there for 6 months. But they go on military planes, they come back on military planes, and the current plan is to keep them on base for 3 weeks after they get back and monitor them there. That's probably more protective than we need because they're going to be building buildings. They're not going to be caring for patients while they're there. So the military is being overly cautious, but they're the military, so they can do that. Okay. Now, one of the things about the screening is that it's not exactly new. There's been screening going on for a variety of diseases. Some of you may remember there was the animal foot and mouth disease outbreak that was in England maybe 15 years ago. There was a lot of screening being done when you came back to this country if you had been on a farm or otherwise been exposed. They want to prevent transmission. So it can happen for animals. There was also screening that was being done back in the early 2000s for SARS, and there's been other screenings that have occurred. I was reading the history book about the history of public health in Minnesota, and in the 1860s, 1870s, the Secretary of Health lived in Red Wing, and the ships would come up the Mississippi River, the St. Croix River in that area, and drop off passengers who were moving to Minnesota. And the Secretary of Health would go down to the dock and watch people get off the boat and kind of evaluate to see if they were sick or not, and would just do a quick check. So when SARS came along and we came up with the plan, it was to have CDC health workers at the airport watching people get off the planes and see if they look sick or not. I thought, we haven't advanced very much in 150 years, that we're just kind of looking at you to see, you're looking a little peaked today, you look like you're a little feverish, not so great. But we have a little bit more sophistication with this situation. So there are 5 airports that are screening people coming from West Africa. They're only allowed to arrive in this country at those airports. And that's one way of screening them. So they get screened first when they first arrive in this country. Then they may be coming on to Minneapolis or to another city around the country, and the health department is notified of those people. There is a quarantine station at the Minneapolis-St. Paul International Airport. So people are being evaluated if they come in. And if there are sick passengers, there's a special protocol. And I can talk about that a little bit too. But there's a question. Yes?
Do they by any chance evaluate people in Africa before they actually get on
Yes.
an airplane?
Yes, I didn't say that very clearly. This is what happens before they get on the airplane. Yeah.
They're already here?
Yeah, no. So before people get to leave, they're evaluated to see what their situation is. And then once they get here, they're evaluated again. And then,
I have a quick question.
yeah,
So the screening, how do they actually test? Do you have a medical test?
all right. I happen to have the packet that people are given when they arrive in this country. So at the airport, if you come, you originated at one of the countries where Ebola has been found, you're given information and someone talks to you. So here's what you get. And I'll pass this around. So everybody gets a thermometer. Because not everybody, it turns out, has thermometers at home. So I'll just pass that around. I'd like to get these back when we're done. So you also get a little card that says check your temperature, and if you have a temperature of 100.4 or higher and you have any symptoms, to call the health department. Now we're also going to be calling you every day. So you get a intro letter that says all of the things that you're getting. You get sort of a pictograph of all of the things to be watching out for. Don't share your thermometer. Don't take it right after you eat. So again, not everyone is as familiar about taking their temperature, so here's information about how to do that. Here's the phone numbers of all the health departments, including Minnesota. Here is welcome to the United States, with all of the things that we would like you to pay attention to, 1 through 6. These are what's in the packet: the thermometer, the directions, a health advisory, symptom card, and a check report and phone numbers. So then you also get a log or a little diary to write down your temperature and any symptoms that you've had, and it lasts for 21 days. Now, either the state health department or the local health department will call you every day and check in with you, and I'll talk about that in a little bit. And then just another little general information. So we are working across the country to do this at all of the airports. This is a picture of where the quarantine stations are in Minneapolis, St. Paul, because of our international travelers. We have had one of those for a number of years. So this goes to information, this information goes to anybody who's traveling here from Guinea, Liberia, Sierra Leone, or Mali. Those are the 4 countries that currently have active outbreaks. Nigeria and the other country that I can't remember right now has already been taken off the list, and Mali was just added a couple of weeks ago. They're given the information about Ebola, they're given information about the symptoms, and if someone arrives and they're sick, we have a protocol that will take them from the airport to a hospital for more evaluations. Travelers undergoing screening measures answer some questions about their health, have their temperature taken at the airport, and they're evaluated to see if we have other symptoms. So again, it's not too different from when they got off the ship, but a little bit. Yes. 100.4. 0.4. Yeah. Yeah, 104, you should go to the hospital regardless of what you got if you have 104. No, it's 100.4, sorry. It's a great question. I think there's like 7 or 8 languages that they're doing, and they have access to interpreters for if someone comes and they don't speak one of the languages that they thought about for that country. That's a great question. I meant to say that. It is available in multiple languages. That's been one of the things that's important. Yes? How many people have they trained to take care of patients with Ebola? You know, I don't know. CDC is supposed to be announcing the hospitals that are prepared to take care of patients with Ebola. In Minnesota, we have 4 hospitals. And what we learned from Nebraska, which has had a specialty unit, and Emory, which had a specialty unit, that you need to think about 40 staff to take care of 1 patient. Because again, of how limited your time is in that suit, how hard the work is, emotionally and physically, in the 24-hour shift. And so it takes a lot of people. So it's hundreds, if not thousands of people. Yes? Mm-hmm. Is there Ebola in the Democratic Republic of Congo? There had been. They don't have any cases there now. No, it's just that like Lyme disease is named after Lyme, Connecticut. When they found this virus, they gave it a name, and they said, well, we found it near the Ebola River, so let's call it Ebola. That's all that meant. It's just, as opposed to calling it, orange or purple, they called it Ebola. So, and that's fairly common for the emerging diseases now to be named after the location where they're found. That was a great question. Let's see. Oh, sorry. Yes.
So from those papers that you were passing around, they're really nice, but I was kind of laughing a little bit about it. Said, "Oh, welcome letter." I can't imagine myself arriving here and getting that welcome letter.
Yeah, so glad to have you here. Yeah. Yes. Well, I think what happens is someone who's traveling here, they are evaluated at the airport they start at. They're evaluated at the first place they stop at, and someone talks to them. And I think it is it's kind of scary. You know, first of all, it's the government, which not everyone thinks is the most wonderful thing in the universe. There's someone that talks to them. And then we, the health department, get sent their information, and we make a phone call and talk to you about what's going on and answer questions. And what happened last week? Well, one of the things that you should know is we never have an outbreak, or we always seem to have outbreaks at 5 o'clock on Fridays or the day before a holiday. I don't know if you have experiences in your work that's when things kind of get all a little bit extra. So we had someone who had arrived here and had some of the symptoms that we saw on the chart that we talked about and needed to be evaluated. So getting that person to the hospital and getting them cared for. It turned out to be negative, which we're very thankful for, but it was a little scary for a little while. So we are ready and we are watching. We have probably about 75 people that we're monitoring at any given time, because there's a fair amount of traveling that's coming from those countries. Yes?
But they aren't restricted to anything.
No.
Unlike the woman in Maine who had the.
Right. Well, we go through basically an evaluation process to determine what your risk of exposure would have been. So if you'd had a needle stick back in Sierra Leone and came back to Minnesota, we would ask you to limit your activity and your external activities. But if you happen to just be from Sierra Leone, we would just say, take your temperature and let us know. So we really vary it depending on the person's situation. Yes, another question.
My concern is that this is all based on someone being completely honest. What about people who had family members and, because of that, they want to get here, maybe other healthy family members, and maybe they're not as honest.
Well, there's a couple of, the question was about what happens if someone doesn't tell exactly the full truth and things happen. I think there's a couple of safeguards in place. One is that they're all screened before they leave the country that there's exposure in. So they're all evaluated before they leave. They arrive here, they're evaluated again. They arrive to Minnesota or wherever they're going, and we are in touch with them for 21 days. So if you start to get sick, we are in touch with you. And there's a lot of conversation and there's a lot of effort. Doesn't mean someone couldn't slip through the cracks, but we haven't seen that so far. Because it's a pretty scary disease, and most people, if they think it's likely, they're wanting help. Because the earlier we can get you into care, the more likely you are to survive. There's another question. Yes? No. The question was about the man who died in Texas. The screening protocols and things that I'm talking about were put in place after that. I think we learned an awful lot, unfortunately, from his situation and his death, and we've put a lot more things in place that we wished we'd had in place for him. Yes? Well, it was found in some animals, and we're bats and chimpanzees and gorillas and what was the other one I said? Monkeys. So we found it in some animals, and there may have been animal bites or some other. So it was first found in animals. It's one of those diseases that we're now starting to see. It's like HIV/AIDS. We didn't have it, and now we do. So yeah, it came from animals. Was there another question toward the back? No? Okay. I think we already talked about that. And there's the airports. You can't read that, so we'll just keep moving. All right, we've been monitoring travelers since the end of October, and started out with Liberia, Sierra Leone, and Guinea, and now Mali has been added to that. One of the things that we need to be watching for is, will there be additional spread to other countries? Because the United States now is a country in which there's been Ebola transmission. And I thought, all of the fussing and stewing that there was about, all of the people coming here from other countries, well, there was some country debating whether or not they should be screening people coming from the United States to their country, because we're now in a state or a country that has had Ebola transmission. But again, we're looking for fever and other symptoms for 21 days, and we are looking to swiftly find someone, and that's part of the educational activities. Is we want you to know that if you start to develop symptoms, we want to help you because we want you to survive. We get the information, we contact them, and if you're in a higher risk, as I mentioned, I already talked about this. All right, we give you some additional guidance. We do have the authority given to us by the state legislature to do isolation or quarantine. I want to talk about that just a little bit. Right now we're working off a voluntary. People have been very cooperative. But we do have the ability to do isolation, which is once you're sick, to restrict your activity. So we can, if you're sick and you have symptoms and you're not being cooperative and you want to go ride the bus and cough on people, we have legal authority to restrict you and put you in a hospital, I guess I would say. Quarantine is the word that you'll often see tossed around. That is, you're healthy, but you've been exposed. And maybe you are in the midst of developing the disease. Now that's really an issue for a disease like smallpox that's airborne. I talked about that earlier, that it just kind of hangs in the air. Again, with this particular disease, because you're not infectious before you're symptomatic, and because we're now monitoring pretty closely, we are not putting a lot of people in quarantine. We are sometimes doing a lot of follow-up. And so if you have a person who develops Ebola, we're going to be in touch with all of the people that you were in touch with. And so there's a little detective work, because so where did you stop and get a sandwich? Do we need to look at the people there? All the people on the airplane that you were with, things like that. So it can get to be a fair number of people. We do need to be aware that if we put someone in isolation or quarantine and we take away your ability to move around, that we need to then help take care of you. So we need to make sure you've got food. We need to make sure you've got a means of communication so that you can call or text your family so that you're not limited in any way. So the woman in Maine who was in the tent with no showers and it wasn't heated, that we have laws in Minnesota that would have made that that wouldn't have been a choice we would have made, shall we say, because that would not have been a reasonable accommodation or the least restrictive means. And I think she highlighted, let's be reasonable about things and be more thoughtful. We have 4 hospitals in Minnesota that have stepped up and said, we want to be prepared to care for an Ebola patient. And that's Fairview University Hospital, St. Paul Children's, Unity Hospital, and Mayo Clinic. Any of you work with those groups? No? Okay. Those are the places that we would look to first to take an Ebola patient. And they have done a lot of evaluating their hospital to see, once you come in the door, how far is it to get to the room and how do we protect anybody you might come in contact with. They've looked at their ambulance services. I have a niece who's a paramedic, and they are training how do you take care of someone, how do you put someone in an ambulance, and then how are you going to clean that ambulance. And she especially likes when she gets to be the Ebola patient and lie in the bed and let them fuss over her. They've worked on training. They've worked on identifying staff who are willing to step forward and do this, because this is not easy and simple. And It's not probably going to be very effective if you say to people, I don't care whether you want to do this or not, you have to do it. Don't know that that's the kind of person you want taking care of someone with Ebola or being confident in the training that they've gone through. There's a lot. I talked about the personal protective equipment. I want to show again another picture. Here's another. Oh, I'm just so sorry you can't see these better. But this is, again, probably an even more higher level of protective equipment that some hospitals are looking at. But again, you can see the booties, the full get-up, the hoods. This is the one with the mask on it. Again, that is not a very comfortable set of clothing to wear, and would not be very comforting if you were the patient in the bed, seeing people looking like this coming to take care of you. So there's a lot of extra work that goes into taking care of someone. So what's happened in Minnesota? I talked about a few things, but we have an information line that people can call if they have questions for the general public or for healthcare providers or anyone who has questions. We have a bunch of materials, and we'll talk about those in just a little bit. And then we've worked with the laboratories around the state so that they feel safe in drawing the blood that's needed to do the test and can do the first round of testing, and they can protect themselves and their equipment. We've also, we are one of the designated labs at the state health department to do Ebola testing. So we're able to do the testing here in Minnesota. We always, when we get a specimen in, we divide it in half. We send half to CDC and half we test ourselves. And that patient I talked about earlier, they both the CDC and us tested negative, which is great, because if one had been positive and one had been negative, I wouldn't be here today probably. We'd still be fussing. We've gone through infection control practices. What is it going to take? What do you do with the waste products, the linens? Do you have to burn them? Probably. What do you do with them in the meantime? Where do you store them? How do you transport them? Who's going to burn them? So we've been working through that. We're working with the Pollution Control Agency, so there's a variety of options that we've put in place. That's not something we normally think about, hospital waste issues. We've done an exercise with 20 state agencies to talk about everybody's various responsibilities. What's the Department of Administration who helps make sure all of the systems are in place to pay for things? What if it's a child care setting? So we've had a variety of agencies. What if it's in a school? And we've been monitoring and help get people to care, as I mentioned our situation last week. One of the things that helps us feel a little more prepared for this in Minnesota is our experience with someone last spring. The end of March, so right around when it's starting to get nice out and it's not snowing like it is today. I don't know if you've noticed. It's beautiful out, isn't it? Yes, it is. Some of you didn't make a pretty happy face when I said it's snowing out. So in March, we had a person come back to Minnesota from Liberia who had a fever and was confused and was in the hospital. And so the hospital was kind of nervous. And we thought there might be some kind of viral hemorrhagic fever, and we were concerned of Ebola is one of the things that we evaluate. So we sent it to CDC because at that time we did not have the ability to test ourselves. And it came back positive for Lassa fever, which is also a viral hemorrhagic fever. That means that your organs start to bleed. And it can be a very mild case. Unlike Ebola that I talked about with a very high death rate, it can be very mild with very few symptoms, or you can develop the bleeding disorder, and you can even develop deafness, which is one of the main results of Lassa fever. So the hospital that cared for this patient, deafness is one of the potential outcomes of Lassa fever. Not Ebola, but this other disease.
Can you spell that fever? Oh, this fever.
Oops. Did I say it?
How long does it take to get results back from the CDC once you send in your test?
It depends on the disease, but for these diseases, we've been able to do the test within 5 to 6 hours.
So when you send it to the CDC, they get the results back in 5 to 6 hours?
From the time they get it.
So does each state have their own CDC office, or does everything get sent to Georgia?
There, I think, are 60 laboratories around the country that can do the Ebola testing. Minnesota's one of them. And other states send it directly to Georgia, to the Centers for Disease Control.
That makes sense.
That makes sense? Okay. What was I still saying? Okay. Here's when I talked about the contact follow-up. And if you wanted a job that was kind of like a detective, only you didn't have to wear a gun, become an epidemiologist, because we identified 169 people that we needed to find and follow for 21 days for this individual. We did not have any transmission, so no one else developed this fever. So that was making us feel a little better. We had an excellent hospital. We had good practices. People did the things they needed to do. The individual recovered, did not go on to develop deafness. So I want to talk a little bit, okay, I want to talk about something else for a little bit, but see if there's any other questions of anything I've covered so far. This is a very complex, multi-layered situation. Yes?
So if it's so like incredibly infectious, why hasn't it spread throughout the rest of Africa, even with all the protections that people there?
Well, again, it's both fairly infectious and fairly not. You have to be pretty close contact with someone. You have to be within 6 feet of the droplets. And then not everyone will get infected. It's not 100%. And so if you're not within 6 feet in close contact with someone, it's not going to spread. So it's really spread person to person.
So if let's say somebody sneezes and you get a droplet on their arm, you have to let it get
It has to get to it has to get to a mucous membrane. So just having someone sneeze on your arm, although icky, unless you are then getting it up to your nose, or your mouth. So it's, when a person is very sick and putting out a lot of fluid, it's hard not to, if you're pretty close to a person, to get some of those body fluids on you. So I think that's what happens. Family members are caring for their family members, and it's spreading that way. So, yes?
I think early on, and maybe they didn't know that much, but I feel like they didn't really say, from all the things they were reading and watching, they didn't say that, like, massive amounts of body fluid
Mhm.
out. So they really, it kind of made you question, are you sure it's not just bleeding and that? Because they never said, there's bleeding from the ears,
Right.
and vomiting,
Right.
and so I think we can
I would absolutely agree with you. That was not that's become more clear as time has gone on, and the fact that you're more infectious, the further on you get, that you're not the same all the way along, you go up in your infectiousness. So we're learning more, and as I said, you'll see an article in the paper today of we're doing a lot better, and then you'll see an article, well, it's still really bad, and we're doing a lot better. And so I think there's still some of both of those things going on, which makes it hard. So I want to talk just a little bit about people who are in Minnesota from these affected countries and some of the impact that it's had on our neighbors and friends and coworkers. We first began to see refugees from Liberia in the early 1990s, and that's continued through sort of the mid-2000s, and probably still some additional ones. We have, as part of that, 4,000 refugees settled in Minnesota, so we now have about 10 to 20,000. It's hard to really know that because many people first came to another state and then moved to Minnesota because I think our weather, because it's very much like Liberia here, right? So no, for family, for friends, Minnesota is known to be a good place for a variety of services, for employment. And I think if you're moving far away from home, you want to be close to people you know or that are kind of like you. So we've developed quite a larger group, mostly in Brooklyn Park and Brooklyn Center, in that part of the state. And for Sierra Leone, again, started in the 1990s with primarily through the last 10 years or so. We've got about 400 primary refugees with maybe 500 or so that are here from Sierra Leone, a smaller group. And then Mali, we don't think we have very many, maybe fewer than a dozen people that are in Minnesota from Mali. And from Guinea, again, we only know of 26 primary, which is they came to Minnesota originally, but there's probably some others that have joined them. So those are the countries and the people that are represented, with Liberia being the primary country that's most likely in Minnesota. There have been a variety of meetings and a variety of outreach, but I think it's still really difficult for us to fully comprehend what it must be like to know so many people back home have gotten sick or have been exposed or have been worried or have been affected by this, and many members of their family affected by this as well. So it's hard to really understand what that would be like. Yes? Well, okay, great. The question was what do they do to treat? And I'll talk about that in just a minute. So you're just ahead of me. So we've done a bunch of meetings. We've had conversations. We've done all the materials that you see in front of you and trying to get the word out. We do have fact sheets. They're available in English, French, Hmong, Somali, and Spanish. And that's one of the materials that you have in front of you that the health department did. There's one that's called just Ebola, and that's a fact sheet. And then we also have the frequently asked questions. The frequently asked questions. So again, something for you to take home. The two colorful ones, one that's really tiny and is an eye exam, actually. 10 things to know about Ebola. First of all, your dog or cat is not spreading Ebola. That issue came up, and they've put some animals in quarantine, and it turns out not to be an issue. Food and drink from West Africa are safe to eat and drink. Mosquitoes may be the deadliest and the most annoying animals in the world, or insects, but they don't carry Ebola. It is not spread by mosquitoes. Family members, coworkers, and neighbors coming back from countries don't pose a danger to you and your family. Household bleach and other disinfectants kill Ebola. If you're feeling sick, you should be thinking about influenza, as someone said earlier, not Ebola. It's not airborne. We talked about that a lot. It's okay to travel on the plane, and it's only spread once you have symptoms, and you can't get Ebola from a handshake or a hug. The other handout for you to take home is how to talk to your children about Ebola. I would imagine that that's a concern for kids who hear bits and pieces on the news or hear people talking about it, and this is a little guidance for you as you think about talking with your children or the children that you work with at work or your colleague or family friends and their kids. There's some other stuff on our website. Okay, so one of the questions about, so what can we do about it? So do we just have to wait and see what happens, or do we have things? One is a vaccine that prevents it in the first place. I'm sorry, did you have a question?
What about sex? Like semen, breastfeeding?
Body fluids, yes. Yep. And it's, I wasn't going to say this, but since you asked, it's been found in semen 1 to 2 months after the person recovers. So it takes a while for your body to clear the virus.
So is it a similar concept as HIV?
Yes, yes. Once the virus is in your body, it takes a while. But it does go away. It doesn't stay forever like HIV. You stay infected. So They're working on a vaccine, and they were just talking about it on the news yesterday. They've had promising results. It appears to be safe. This is well, you can't see it well, but it's a picture of a woman who'd volunteered to get a shot with the vaccine to see is it safe. And I admire people who step up to do that. That's an amazing thing. There'll be more studies. It may take years before we have a fully developed, readily available vaccine. And then you have to work on delivering it and getting it accepted and having people understand why it's important, that it's safe, that it isn't a government plot, those kinds of things. So it's not a simple procedure even once we have a vaccine. For treatment, unfortunately, it's like many viruses, like a cold. There's not a treatment for a cold virus. With Ebola, again, you have to let your body kind of process and manage and develop the antibodies and fight the virus. So in the meantime, what you do is make sure they get fluids, that they can breathe. They may need breathing assistance and go on a respirator or ventilator. They may need, their kidneys may shut down. That happens that happens fairly often, and they may need to go on dialysis. So it's that kind of supportive care to help your body fight off the virus. Now there have been some sort of experimental things that people have tried. There's something called ZMapp, which was used on a few people. They've used blood transfusions, and they've had some other experimental drugs. But the numbers are, we don't really know yet whether those things are helpful. There's not been enough of those drugs or activities to know whether those are really helpful or they just happen to happen at the same time. So there's a lot more work that needs to be done there. But we do know the earlier you get in, the earlier you get treatment and get your electrolytes balanced and have someone keeping track of you and helping you, the better you are, the chances of surviving without symptoms or any impact is much greater. So our emphasis is on both prevention and on early detection. So again, to just kind of summarize, largest Ebola outbreak in history. We have a large population of residents in Minnesota with direct ties to Africa, West Africa. In fact, I think we've been told we have the largest concentration of people from Liberia outside of Liberia itself. We've also seen that fear can overcome common sense. And again, kids or one of my friends said at her senior center, a lady said, "Oh, I just don't feel good. Maybe I've got Ebola." And she's traveled from her house to the senior citizen center and back home again. We need to make sure we're using science and making science-based decisions. We need to help and support, and you've seen some activities by this country and other countries to work on stopping the disease in West Africa where it's starting from, and not just be thinking about ourselves, but making sure that it gets stopped. And we must be on our guard while there are diseases going on, and that's contact information. But if you go to the health department website, it's just health.state.mn.us, and then on the front page you can click on Ebola and get a bunch of information. And I've gone on a lot longer than I thought. I was asked to talk for an hour, and I've talked more than an hour. Who'd have thought? So any last questions or thoughts or advice?
Yeah, I have a question up here. I know there's a lot of information that's out there, with social media and whatnot, news. Sometimes I feel like they're intentionally trying to scare us. Like, that's how we actually read it, and
Yes.
we're all checking in to make sure that we're all okay, but
Yeah, and if you watch the TV news, it was like, Ebola, the world is coming to an end. Yeah, and then what's the next thing? And then now Ebola isn't talked about a lot anymore, but it feels like it's all about getting ratings and not always the full accurate information, and it's hard to counterbalance that. So I talked about fear.
but it's really sad because we lose trust in the system.
Yep. So I'll give you the same advice that I gave to one of my colleagues after 9/11 when there was TV all the time. Is turn off the TV. Do something else, because be realistic. Yes?
So how do they determine when someone is well enough to either leave the hospital or, I mean, does it vary the time frame, how long it takes anyone to either
Yes. I think it's a combination of the symptoms, your virus level. Do you have family support? Are you able to follow through? What I think we've seen in the folks who have survived and have gone home in this country is that they're exhausted and their stamina is really affected for several months. So, but you don't need to keep someone in the hospital for several months while they're tired.
And other than it being immunization, it wasn't in the blood, or it wouldn't be once they're tested.
It's going to be very low levels. Yes. Well, it sort of depends on which country you look at. Yeah, in West Africa, Liberia, the rate seems to be slowing. Mali, it's very concentrated in one area, so it's a very small number of cases, but they're watching very carefully. Sierra Leone is still, the rates are increasing. They're still seeing more cases. And Guinea, I think, is kind of holding its own. So the numbers are still going up, but they're not going up as fast. They're going up more like this. So it's not by any means stopped and over. It's still a problem. But I think the original estimates of several 100,000, if not more, people affected is not going to play out. So thank goodness. So. Yep. Yep. Well, and I think part of the helping people who are taking care of family members to be safe while they're doing that has been part of the emphasis. So. Well, I thank you for your time and attention today, and I wish you a safe and not too terribly cold winter.